Thanks everyone for joining. This is a regular series. We run monthly CPD events. In this one, we have Andrew talking about the management of climbing related injuries. But I will pass over to Andrew in a little bit, um, and he can give you a proper intro. We are scan.com. With us, you can access a network of imaging centers across the country. We have an online portal. We have APIs which hook into like practice management systems. Patients can choose the center that they want to, the price point they like, they can choose a date and time. So we try and provide that convenience for patients as well. We also we have clinicians who vet referrals that come in, both on certainly if a patient is referring themselves, we vet those, but also if a clinician is all sending anything through our portal, we also just make sure we vet those just to ensure it's clinically justified, just the right scan and all that kind of business. With all that said, let me get out of the way and I'll hand over to Andrew.
Real. Okay, thank you very much. I'm just going to share my screen and then hopefully it should come up for everybody. Does that look good, Tom? Is that okay?
Yeah,
I
all
suppose
good from
people
my
will
side.
say, if not, yep, fantastic to see so many people here. My sort of motivation behind this is to start trying to spread knowledge around um, exercise, or sort of sports medicine, I suppose, around climbing and climbers as it's becoming a more popular sport. I have seen a couple of names I know on the list. I just had a quick look while Tom was talking. So, hi guys. But this is I'm hoping to touch with people that are maybe not familiar with climbing as well. I am happy to take questions as they come. With something feels really pertinent, we can obviously also put them at the end, as Tom was just saying. But I'm also happy to carry on discussions and stuff outside of this. If you have a question that hasn't been answered during this, feel free to get in touch with me, Instagram, email, or what have you. That's all totally fine. So, right, we shall
Andrew,
crack on. Yes.
just in terms of who's here on the call, so about 50% we have physios,
Yep.
about a third is osteopaths, and then we have a few chiros and then sports therapists, just
Cool.
in terms of who you're speaking to tonight.
All are welcome. That's fine. Brilliant. Good stuff. So, agenda. We shall crack on. I'll just put those through. I'm wanting this to be useful, practical for people. So it's taken me a while to sort of narrow it down and look at a few different areas. We'll have a quick look at what's happened with climbing and maybe why we're here talking about it now as it's grown so much, what we commonly see, injury patterns, where they come from, differences by gender and age, some practical tips both around what I do in practice, which doesn't mean it's the best, but what I do daily, what to look out for, how to differentiate, how to know when to refer on, how to know when to image, that type of thing. So we'll have a look at a bit of that with relation to the finger, because for most of us, certainly in physio school, we don't do an awful lot with the hands, and so we can be a bit lost. I was saying to Tom before we started this that a lot of this, people will come to me with a climbing injury, having been to their existing trusted physiotherapist, osteo, chiro, and found that they've just not got the level of understanding to be able to treat the injury either around the sport or around the body part. So yeah, hopefully we did educate around that. Little bit about me. Been climbing for 32 years. This was just I went through my Google photos or what have you last night. The ones on the right are all climbing from this year, so a bit of bouldering in the lakes, some high mountain stuff in Scotland. Went to Fairhead in Ireland. Been to Morocco. Been to Spain a couple of times. That type of thing. One of the great things about climbing is it does get you out and about. I also over on the left side of the screen, I do make some products. I coach. That's one of the people I coach at the top left there. Um, yeah, got sort of quite a lot going on, workshops, talks, that kind of thing, trying to spread the word. I do work with a varied caseload. I do work with World Cup international competitors, that type of thing. But the majority of my work is with normal climbers, and I will put that in inverted commas, quite similar in a lot of ways we'll look at shortly to a lot of sport people who get fairly obsessed with what's going on. I do work with ongoing issues, chronic issues. Lower limb is often people will say, do you only do the upper body, that kind of thing. There was a great piece of research a few years ago that summarized, basically said that climbing spares no part of the body from the risk of serious injury. And it really is right from your fingers to your toes. I get some weird and wonderfuls this year. Yeah, so 2026 already. I managed a high ankle grade 3 sprain, acute in the South American jungle via a satellite phone, which required a 2-day donkey evacuation, um, and a rupture of a deep transverse ligament in the hand in the MCP in Singapore. I think that one was that kind of thing. So a lot of remote work goes on, not always by satellite phone. So really varied. It's a really interesting caseload. Right, enough about me. I've left this should hopefully kind of play in the background as a bit of an idea that people who aren't familiar with climbing can see sort of what goes on. And I've put this in because I remember having a conversation with a consultant once who had cleared a youth climber to return back to climbing. Their impression of climbing at that point, this was a few years ago, was remembering back to when they were in scouts and they had some big hiking boots on and were, top roping up an easy climb somewhere as their experience of it as an 8 or 9 year old. So they had thought, yes, that's fine. This child can go back to climbing. I sent a YouTube video, not this one, but something similar along to the consultant to say, this is what you've said they're okay to do. And it was the quickest response I've ever had from a consultant back saying, no, they're not, they're not cleared anymore. Don't do that. So climbing has changed an awful lot. We'll look at that shortly. It is now a mainstream sport. It's an Olympic sport. There's over 500 climbing walls in the UK. Um, I think really somebody that's been climbing for 32 years, I've been coaching for 17 years. I've seen this change happen. And really, I think all that's happened is that more people have been able to see what an amazing activity it is. It's very open, it's very inclusive. You can have a group of very mixed ability, can all go to the wall together and all have individually and collectively a great time. It's very sociable, or it can be very individual. You can just go and put your headphones on and climb on your own if you want that. It becomes people's physical challenge space, their mental health space for some. It's a never-ending challenge. It's a bit like golf in that you will never master climbing. There will always be something that you can't do and something that you need to keep learning. And in some ways, I think it's a little like sort of the CrossFit High Rocks kind of phenomenon, in a really supportive community atmosphere, a really engaging activity when you're climbing. There's no space to think about work, bills, family stresses or whatever, that kind of thing. So the place that it holds in people's lives means that when they get injured, it's a real issue, which we'll come to. I do get people, emotionally upset in assessments, which is I don't think is to do with me. This is a common thing, in that they're so attached to it, it becomes part of their identity. It's their tribe, and an injury threatens that, and it can be quite a big deal, really. Um, so yeah, we've also had a great big increase along with that. Social media, people monetizing the sport, business is now well and truly in climbing. People selling lots of ways to get stronger, to get better, to this kind of thing that essentially pretty much just leads to lots and lots of overuse injuries, similar to a lot of other more mature sports. So quick roundup of where climbing has been. Is this going to behave itself now? Move on to the next slide, or am I just going to keep scrolling through YouTube forever? There we go. Thank goodness for that. I'm going to go down the YouTube rabbit hole. So is it a sport that has high injury rates? We don't not really, to be honest, 100% certain still. Round about 4.2 injuries per 1,000 climbing hours. So a similar injury risk to things like baseball and handball. That might be handy for some people. For myself, I don't know anything about baseball or handball really. So I was left with that thinking, well, what does that sort of really mean? Football, round about 20 per 1,000 hours, and rugby, round about 40 per 1,000 hours. But the interesting one for me, that the 1 year prevalence of rock climbing injuries appears to be around about 50%. The definition that we're using within here of injury, it is for me it's something quite a high level really, something that will take you out of the sport for a while. You have to actually stop doing it. For myself, my sort of definition of injury really might be something more along the lines of it stops you fully participating in the way that you want to. You're having to make some sort of adaptation. So these numbers, although may appear quite low, I think are actually possibly a little misleading in some ways. Up to 93% of injuries within climbing are overuse in origin. Even the ones that climbers themselves think are acute. So most people think of climbing as some kind of an adrenaline high risk sort of sport. It's generally not. It can be if you want to go and search that, but for most people it isn't. And there's thankfully relatively few sort of acute injuries, but when they do occur, they tend to occur from things like falls and tend to be quite high consequence because of that. But 93% of them are overuse. And that basically means that they're preventable, doesn't it? Which is a big part of what I do actually is almost try and put myself out of work by looking at injury prevention within climbing. One that may mean something to people who have an awareness of climbing. So most common injury grades are these grades noted here: 6B plus to 7A plus in routes, 6A to 6C plus in bouldering. They're the two different grading systems, or two of the different grading systems that are used within climbing to rate the difficulty of a climb. These are what I think most people would describe as mid to high grade sort of levels. Yeah. And the inference from this really is this is when people have got embedded in the sport, spent enough time in the sport to have developed to these sort of levels, because it is a highly technical sport as well as a sport that requires strength, and are probably then doing it enough that they're racking up the hours to pick up these 4.2 injuries out of 1,000 climbing hours. The classic that I see most often is people will start once a week. They like it, so they start going twice a week. They start making contact with people down the wall and such like, and they will ask, how do I get better? How do I get to be able to climb as well as you do? That type of thing. And the advice is often you need to climb a bit more, which is good advice in a way. But if you go from 2 sessions a week to 3 sessions a week, which is what that person then does, you've just increased your load by 50% in one go. Yeah, from 1 week to the next for somebody that might be quite new to the sport. And these are the kind of load errors really that happen within these grades where people are keen, but maybe don't quite have the knowledge and the expertise. Yep, but when this was done, which was actually only 2024, this study was done. 42% of females and 27% of males seek professional advice. This is for that high level of injury that's actually probably going to take you out of the sport. So even at that high level of symptom, um, males are not seeking professional advice. That may come as not much of a surprise to some people. Quick focus on those early years, and finger development in particular. I'll leave this slide up and I'll sort of talk around it. It's been an ongoing argument within climbing about whether newer climbers should train their fingers in order to make them more robust so that they don't injure them when they're climbing, or is this load onto fingers that are new to climbing actually just going to be too much by itself anyway? It turns out not to be too gender specific again, but the highest risk population are young men who boulder. So bouldering is the non-roped version of climbing that tends to have harder moves and be more intense. And I'll leave it to your imagination as to why it might be young men in particular that have a tendency to overdo it and end up with finger injuries. Um, yeah, but it applies in general anyway. It seems to take a couple of years for people to sort of really bed into the sport. That's a generalization. But we also are now getting a lot of people coming into climbing from other sports. It may be that CrossFit background. It may be they were gymnasts when they were younger and they've sort of come out of that. That tends to be a sport that people don't often carry on into adulthood, and they're looking for something else. So they can come with a really strong athletic background. They are strong. They have endurance. And the rest of their body is fine with that. They probably haven't ever really dangled off their fingers very much, though, and that is what they will be predominantly doing when they come into climbing. So this first couple of years is a real key part of injury prevention and where we see a lot of finger injuries. After about 7 years is what it's thought for the connective tissue to really build its robustness, there is a drop off. But that also doesn't mean that after 7 years, your fingers are bulletproof. If you're continually pushing yourself, then you can still get finger injuries. And yeah, people do. Um, this is looking, I've taken this from another presentation I do that has a section around female climbers. I've just noticed at the top I haven't taken that off. And this is back from in 2018, and there is a difference in sort of injury prevalence within genders. Males most frequently injured with the fingers. Same with females, but there's a difference and in particular with the shoulders. And there's new data coming out now around the change that we've had in climbing, and what is happening now in climbing with the setting and the style changes. It used to be, if you looked at the video that I played earlier, climbing used to be reasonably static. It would be all about how strong are your fingers, can they hold onto a tiny hold and pull really hard. Now it's leaping and jumping around and an awful lot of dynamic movement and control and challenges to shoulder stability. So we're seeing these numbers change, and I feel if this was done again now, we would see shoulders being a higher on the list, and that does definitely affect female climbers more. I would suggest it's anecdotal, n equals 1. I think I see more shoulders now than I do fingers, and I see a lot of fingers, about 1,000 a year. I think sort of the last time I totted it up. But this is this information has been seen in other sports, be that football, rugby, ballet, that type of thing, about asymptomatic and scan results, that kind of thing. So an MRI of 50 elite climbers, and so yeah, 70% of them had labral pathology, the glenoid labrum, and 56% of those, it was like a low grade 2, low level grade 2, pushing into that, that really challenges shoulder stability that we would be expecting to see issues from. And as it is in other sports, the thinking is that because of those demands on the shoulder, climbers build up an incredibly high level of motor control and strength and stability within the shoulder, so they can deal with issues that other people maybe not. And again, with the not again, sorry, for just the Winter Olympics at the moment, isn't there? And the name is escaping me. Lindsay Voon, was it? I've forgotten her last name. With her ACL, she was able
Von,
to
I believe, Lindsay
Von,
Von.
that was it.
Yeah.
Thank you. That was one of those that just suddenly pinged out. Um, Yes, and her ability, she's one of these ACL copers, that population. Um, Then in experienced climbers, so 80% with labral abnormalities. It didn't really say what those abnormalities were, but this is where it's been given to a radiographer to have a look at, and they're like, "Ooh, that that shouldn't be there." I would class that as some kind of a pathology, and it's almost, if it's at that level, is this an adaptation? Are labral tears in overhead athletes, such as climbers, actually almost now being seen as a bit of an adaptation to the activity. So, if you get a scan result back from a climber, this is why I'm putting this here, is that we're now hopefully all aware of this difference between exactly what's on a scan and interpreting that in a black and white fashion. That yeah, it's not necessarily that clear cut, and we need to really look more at function, strength, ranges, that type of thing. This is a little um, practical thing for myself, I suppose, looking at shoulders. So we're sort of a little bit on the subject of shoulders at the minute. And this is my favorite way of having a look at external and internal rotation. And I'll blip through. This was a video I did for Instagram a while ago. But essentially, to go into that position that you can see, you can't quite see maybe on the video just at the moment, but I've got a marker in my hand. Yeah, and we reach back as far as we can, just making sure we're not doing anything too daft with the chest and leaning back, and go through the available range of the shoulder. You do that in different colors if you wish, on different sides, and I then take a photo of that. Oh, it's going to do the same thing again, isn't it? Let me skip through from here then. And then use an app. This is a free DIY app that I use that just measures angles. I thought this was an interesting one, both because it's a recent patient and she was quite happy for me to use her info, obviously. But also look at that range. Yeah, 227 degrees on the right side there, and 205 on the left. The one we've actually got a bit of an issue with is the left. She's lost a bit of internal rotation in the left side. So her unaffected asymptomatic side had 227. We would normally in whatever these numbers always are a bit they need some translation, don't they? Around about 180 is what we would see as a normative sort of data kind of thing. 200, 210 isn't uncommon in climbers, normally with an increase into external rotation. So again, if you've got somebody who's been climbing a long time and they are reporting with shoulder issues, and you look at this kind of thing and you go, oh, blimey, they've got an awful lot of external rotation. That might just again be adaptation to the sport and not actually a clinical finding as such. Um, this is the same patient. Again, this is using the same app. I go through the same body markings, like down to the malleolus and the ankle, etc., etc. I'm sure you can sort of see. It's amazing how replicable, I think that's the right word, that this kind of testing is. I wasn't sure when I started doing it. It is, you can redo it, and it's to within a couple of degrees, certainly as good as, sort of goniometer, which we know can be accurate to within a few degrees. And this is my other, I like this as my other sort of shoulder test, to have a look at flexion and extension. No surprises from looking at these ranges. This patient, as well as being a climber, is a yoga teacher. Some of the rangiest shoulders I think I've ever seen. And this door frame press, basically with the heel touching, sacrum touching, spine touching all the way up, head touching, stops. If you're looking at flexion and extension, it just gives you a real well, literally a frame, isn't it, to work within, and we can hopefully be sure that there's no movement coming from other body segments, essentially, is why I like to do this one.
Andrew,
Yes.
I appreciate I'm very much a layperson.
Yeah.
Those two tests, are they? existing tests that perhaps people on the call here would be using, or are these ones you've come up with?
I'm not going to say I've invented them.
Mm.
The door one is something that I sort of came up with. I'm sure somebody else somewhere will do similar or whatever. These are things that are just like I find quick and easy to do. If you've got a
Mm.
door, you can do this one. The whiteboard one, not everybody's obviously got a whiteboard. You can now get plastic sheeting that like through static sticks to the wall. Yeah, and do that. So if you've got a wall area that you can do it. I think I did see the external internal rotation one somewhere. I'm definitely not laying claim to having
Yeah.
invented that one, or in common with most medically related people, I would be calling it the McVittie test because we all know that people in medicine like to name things after
Yeah.
themselves.
Yeah. Um,
But yeah, I'm trying to give some practical, easy, replicable, stuff that people can do in clinic if they've not
mm,
got lots of kit, and I say it's a free app. It works
yeah.
well.
Just be interested. I mean, you could put in the chat if anyone uses similar or has other
Yeah,
exercises they use. That would be interesting to know. Just
yeah,
if you
definitely.
do, just pop it in the chat. It would be interesting.
Yeah, cool. That would be good. Right, moving on from shoulders more into the hand side of things. What I think we can look at here to do with fingers are the basics. Hands are incredibly complicated. There is a reason why it's oh, sorry, wrong one, gone on too early. It's an entire specialism, isn't it? Hand specialism. And my message here is that this I've got some papers to refer to as well that I feel are good, that give you the ability to be able to differentiate and diagnose these lumbrical injuries and pulley injuries and make a decision as to whether it's okay for you to treat or to refer on. So some real sort of good um, practical research papers that are linked in here, and I'm happy to send out to people and what have you after. So in climbing, these are sort of some examples really of what happens with people's hands and the main sort of grips that we use. So we can use these open hand grips like this one on the left, and then essentially the others are just becoming more and more what you might could describe as bent or closed. And I'm sure if you can imagine then thinking about what we were looking at in that video earlier, that people will hold this, for example, this on the right, this closed crimp, they will hold that, with their entire body weight as a dynamic move with no feet on the wall. People can do that now with one finger, with their middle finger, that kind of thing. There's some amazing stresses get put through fingers nowadays. But to go back again, I keep going one ahead. There is just as much chance of getting an overuse injury from the open hand grip as there is from the closed hand grips. Yeah, if all you do is open hand everything, there's a lot of rotational forces go on with open hand gripping. It's not very stable. We need a lot more effort to control it. That can lead to an overuse injury just as much as one of these often perceived to be more risky closed grips. This is that closed grip looking from the top, the green lines dropping down, just showing what it would be straight, basically, and then the red line going and highlighting the joints and seeing the wonkiness that goes on in the fingers of climbers. This is a perfectly standard. This is kind of what it will look like for somebody to use one of those closed hand grips. So some real flexion through some of the joints and some extension, potentially hyperextension in others, stressing things like the pulley system on one side, and the volar plates and that kind of thing, and just the joints overall, as you can imagine, and the bones within. A quick look at finger anatomy. This is the pulley system at the top here that I'm just going to talk roughly about in relation really to the A2 pulley more than anything else. It is, as you can see, complicated. As with most anatomy pictures, there's a lot of other stuff left out of here as well. So, in real life, it's even more sort of messy and complicated. Things like the retinacular ligaments and such like. And so yeah, the pulley system. I think the next video should hopefully show sort of what happens within the pulleys and what it's actually all about. I'm going to come back. The pulleys keep the flexor tendon aligned with the bone through this multi-articulated finger as it closes. It's described sometimes as like the hooks on a, or the eyes rather, on a fishing line, on a fishing rod that keeps the line in line with the fishing rod and enables forces to be distributed down through it. And we can see here basically what happens if the A2 pulley snaps, which is a pretty common, and I think in this one actually they've removed all of them, A2, 3, and 4. Yeah, is that the flexor tendon will move away from the bone. That's not biomechanically efficient. Yeah. When it comes to things like scanning, if we were looking to try and diagnose this, I used to mess around with, and I thought I was doing well at the time. I would describe it as messing around with like vernier calipers, that type of thing, because research shows that an increase in distance between the flexor tendon and the bone, if that distance goes over 2 millimeters, then we're very likely to have had a rupture of A2 in this case. That is really not detectable, either by pressing the finger or by, as I was, getting the vernier calipers on it and asking people to put a little bit of pressure through it and that kind of thing. Can we detect the difference between the normal excursion, which might be around about 1 millimeter or so, or a rupture, which is 2 millimeters? I mean, sometimes it can go 3 or 4, depending on, yeah, but even so, it's so small that we're really not going to detect it. So ultrasound is kind of the gold standard for having a look at this. And if you think it's anything more than just A2, then that really needs referring on to people that really know what they're doing with these. A lot of climbers self-manage them. A lot of climbers believe that every single pain that they have in their finger is a pulley injury. That's the common one. These occur, the pulley system should be able to take as much load as we can pull through our fingers. They adapt as our strength in pulling adapts, if that makes sense. What happens is that people will overtrain, they will overclimb, they will overuse the pulley system, and the pulley is not in great condition. And then they pull on one move that's just too much, and it does eventually pings and ruptures. It can happen acutely, and that will have a mechanism behind it of an incident like a foothold breaking, or they've slipped on their foot and effectively kind of shock loaded the hand, and the hand often opens out, and it's those eccentric forces and the increasing forces through that really cause the damage. So usually the person will report a loud noise when this goes. A nice differential that I often use if people are climbing with anybody else or inside in a climbing wall rather than outside is, did anybody else hear it? This is the kind of noise that people for a good few meters around will turn around and go, what was that? Yeah, it sounds like a fairly hefty, dry stick being snapped into. The person will often really know that they've done something wrong. This is a ligament. The body doesn't like it when ligaments snap. Yeah, I've certainly, a fair few people will report almost like a shock kind of a response where they've had to lie down. They've gone a bit green, a bit white, and felt a bit sick and had to lie down. So we're looking for, true signs like that. However, I've had loud snapping noises reported that weren't ruptures, and silence that was a rupture. So what do we do? Oh, getting stuck in the YouTube rabbit hole again as we move on. That was just another picture. There is a paper that I'll come to after, and again, I'm sure we can get information out to people that essentially shows and walks you through kind of an algorithm of how to look at somebody's finger if you suspect a pulley injury and judge whether it's mild, which I would suggest is treatable by people that aren't that experienced with hands, through to moderate and severe, in which case I think we need to be looking for outside help, shall we say, as far as this goes. I won't go into the details here because it's all in the paper. It's absolutely fantastic. Kerry Cooper, an American physical therapist, as they go by. But here it is, and I'll leave it on while I'm talking so people can kind of copy that down if they wish. And it was a nice study, I think 50 odd participants, where they suspected rupture. They took them through this algorithm and then confirmed it with a blind ultrasound. And the results that they got of mild, moderate, or potential rupture matched really, really well with what they then found on ultrasound. And so it's something that I've certainly got confidence in using to both diagnose, because it talks about that, and also then how to manage as well. So this is one of those that I think is a really good practical read for people. Within this as well, if you then start looking into the names and the references that they, refer to, that's opening the door for you and some climbing research. The sort of the references within papers like this are the people who are doing the research in climbing and are worth following. This is somebody's hand pulling on an edge, self-promotion. That's one of my edges. It's what's known as an unlevel edge that takes into account the different ratio of finger heights. This is the result of a poorly rehabbed pulley injury, not by me. This was self-rehabbed, as a lot of climbers are. Don't know whether it was a rupture or not, because they came to me many months later basically saying, I think I ruptured a pulley. A2 pulley in the ring finger is the most common for various reasons. And I have, yeah, it's never quite settled down. They could pull as hard with the affected hand as they could with the unaffected hand. So if you just benchmark them, how hard can you pull? All looks okay. But I think, we don't need to be experts in hands to notice that finger is not correctly aligned. And this is what gets missed in the rehab. And this is why anything other than a mild sort of a sprain to the ligament needs somebody basically that does know what they're doing. Because what he was reporting here, it was really kind of like tenosynovitic type symptoms. Real swelling and irritation every time he tried hard, that kind of thing. Looking into the actual treatment of things, if people can be trusted to climb with straighter fingers, basically the more bent the fingers, the more strain goes through the pulley. I have in the past literally just told people to almost like mummify the finger and to keep it straight. Yeah, reduce that crimping, low intensity, long duration pulls on things to stimulate collagen synthesis and help with collagen alignment, that kind of thing. Yeah, and a sort of a gradual return back to activity, but it's the closed hand grip with a pulley that will do it. But it's amazing what people can do. Yeah, if they can keep their finger straight, they can continue to climb. Moving on to the other one that I think we can hopefully deal with, although interestingly, the malalignment in the last picture is due to the lumbrical involvement. The biomechanics when a pulley ruptures of the finger, the biomechanics are greatly altered, and that's what hadn't got back. And the way we get that back is through some work with the lumbricals. So this injury happens usually to lumbrical 4, something called the quadriga effect, I believe. And that's to do with the fact that these all come down to the same common finger flexor. Yeah. So in order to maximally pull with one or two, whatever, basically all of them get involved. And I'll show, I think, on the next picture, if you look at the right hand here of this climber, they're in a 2-finger pocket, a very common hold in climbing. And as they're pulling really hard with their middle two fingers, you can see the little finger and the index finger are joining in. Yeah, they're pulling down together. And that has the effect on, particularly on lumbrical 4. Effectively, it gets pulled in two different directions and it tears, it gets injured. Put through. This position of the right hand here, this pocket pull, doesn't have to be on a pocket. It can just be on an edge, as you saw there. I was even doing it on my own hand. This is also the test position for if somebody has it. People, as I mentioned before, the ring finger is often the most commonly injured with a pulley. So if we've got an injury here with a lumbrical, yeah, I mean the clue really is that the A2 injury, any palpation, it's kind of and symptoms should be above the hand in the finger, and with this, symptoms should be within the hand itself. And this, yeah, this is the test position. You can get people basically to load the middle two and then bring their fingers down very carefully, very gently, yeah, under guidance, and see what happens. And essentially, we can differentiate them between a grade 1, grade 2, and a grade 3. And for yourselves, if not experienced in this type of thing, then, grade 1 strain. Yeah, if they can pull pretty flipping hard like that. I'll leave that up for people to look at while I'm talking, but also another indicator for me as to the severity of things is, where do the symptoms go? If people report at the time an electric shock type symptom, which is what they often describe, and it traveled all the way down the arm, then that's likely to be right up there as a grade 3. Yeah, in that symptoms have traveled along the flexor tendon down to the actual finger flexors themselves. Those two layers of finger flexor, one of them, in this case, the FDP, is heavily under load, and then something that is controlling that goes twang. And these two layers of finger flexors, which usually coordinate very nicely together, get suddenly disrupted. There's a shift happens within them. So I've seen bruising and such like within the forearm from this before, as the damage goes down. So don't just rely on if they've got pain in the hand, well, it must only be a grade 1. It's not quite that simple. But if somebody comes with, reporting either at the time or has symptoms down in the forearm, then that's certainly leave you thinking that we need to be looking at a grade 2 or 3 or some help. This is I'll turn the volume off. This is this is one of the exercises I use. It's called an iron claw, one of the initial. So this is an initial exercise. This lady here is trying to do with her little finger what she's doing with the rest of her fingers. She's trying to keep it in contact with the roller as it rolls up and down. And that thing was doing all sorts. The lumbrical is an incredibly important coordinator of the finger. That's its job, that's its role, is to decide how much flexion and how much extension it is needed to balance out the task for the fingertip, essentially. Whether you're tying your shoelaces or pulling as hard as you can on one of those crimps or a pocket. And if it goes, it's really quite. This lady actually came with wrist related pain. She was getting what she thought was TFCC pain. That turned out to be wrist flexor pain. It was at the insertion of the wrist flexor on that side. But then, yeah, a bit of further testing. That's actually the problem, is because there was no control really on that side of the hand at all. And this is what happens both when we're looking before at the pulley injury, if we don't rehab those properly, and lumbrical injuries, if we don't rehab those properly. My most interesting one, I've just remembered it now, and I wish I'd have put it in actually, was a patient, a guide, mountain guide, been climbing for 30 odd, I think 40 years or something at that point. Really early on in their climbing career, they remember doing something around this, and that pinky never recovered. And it's really interesting. I've got this photo, or I find it interesting, of the adaptation that's happened to their hands and their 9 other digits that have been built to be robust and strong and bigger bones, and that pinky that they have just never used ever since. And it looks like they've got a withered little finger more than anything. It was really, really sad, but it isn't. That's its original size, and the rest of it was all adaptation to the work that and climbing that they've been doing over the next couple of decades. Um, so yeah, this is yeah another. I could have told that story while you were writing this down. Is a really good look at what the lumbrical and FDP muscle tears in climbers. It is based on a cadaver model and that type of thing, but that's obviously has its limitations. But it's a really nice starting point for understanding about the lumbrical, what it does, yeah, and how important it is. So yeah, wanted to get a quick one in around youth athletes. It's a bit of a uh, yeah, definitely a soapbox of mine. Okay, a hill I will die on, all of those kind of things. I'm hoping to start this year actually some research into some aspects of youth climbing, having been a youth coach predominantly for sort of like, let's say, the last 17 years. This again is taken, the side taken from another CPD workshop that I do, and it's looking at common issues. And then the one in the top right there, what are the youth guidelines for climbing? We have governing bodies. We have an international governing body. We have a European governing body. We have in the UK the BMC, are they a governing body? That yeah. Anyway, GB Climbing. We have all these organisations around. We have coaching qualifications. Unbelievably, a lot of countries actually don't. I think that's fantastic. We've done some really, really good work. There are no youth guidelines. I cannot think of another Olympic sport, a mature sport, although yeah, climbing's probably a teenage sport really rather than a mature sport, that has no guidelines. If we look at things like basketball, which will dictate court size, how often or how long somebody of a certain either chronological or developmental age should play in attack or defense because they put different loads on the body, different ball sizes for different ages. UK athletics have got wonderful stuff laid out for all the kind of the different events that they do. Absolutely everything, every sport that you can sort of think of has youth guidelines, and at the moment we don't. And so this is one thing that I'm quite passionate about. This is stolen from a fellow physio, Paul Huffy. I think I've just said his name wrong there. It's Hujuji, I think, if it's actually pronounced correctly, but he's known as Huffy. If there's any doubt with youth in climbing, there's no doubt. And we're going to look at another finger injury that was noted before, and then a spinal issue that we see as well. This, I don't know, I didn't look in the group of Erin Dukes, who made this. I've chatted to her a couple of times the other day, and she was hoping to join. This is a fantastic resource that she has created along with Huffy. If you Google BMC, yeah, growth plate finger injuries, this will come up and you're able to download it. And this has got a lot of the information in that I'm going to talk about. It's also great to give to parents, climbers, that type of thing. But this is really related to peak height velocity, essentially growth spurts. So as hopefully we all know that when bones grow, they grow from the end, and we have the growth plates, and this is the growth plate fracture. This is my attempt at drawing, sort of what happens in a finger when we're crimping, this closed grip. And we're looking here really at the pip joint in the middle and the compressive forces that happen and the roll and spin that happens within the joint, concave, convex surfaces, that type of thing. And the dorsal side of the middle phalanx basically gets pressed against, yeah, repetitively. And it's a stress fracture within the finger that eventually looks like this. So you can imagine as this part of the proximal phalanx pushes up and against this growth plate here as the finger bends into flexion in that crimp position and is then compressed. Although it's a pull in this closed crimp position, we are pulling on it. Once we get to 90 degrees at the pip joint, it's a compressive force into the bones. And this is a Salter-Harris fracture of the growth plate. 6 different types. The most common, interestingly, that happens, this is a type 3, which, as shown here, yeah, there was a study recently done looking at 37 growth plate fractures. Interestingly, those 37 individual fractures were in 27 different climbers. So obviously some of them had more than one. Yeah, and they're an overuse, overdoing it injury. 36 were chronic, 1 was acute. Acute is very rare, and usually gets attention because it's obvious something has happened. But 28 of those 37 were type 3. And they're not quite the worst, but they are really bad. This is many, many weeks off climbing and off loading of that finger, which for teenagers who may either be competitive, or this is just their thing that they've found that they're really enjoying doing. It's their escape from from whatever. It's their social life as well, a lot of the time, all that kind of thing. To take them out of that for 3 to 4 months can be pretty devastating. It's a high effect thing. Again, here's another study. Volker Schoffel and Chris Lutter, again, 2 names to stick into PubMed and have a look around at. The main thing with this to look for, it's most often the longer fingers, most often middle finger, middle joint, pain on the back of the middle joint. So it's not a pulley, it's not a lumbrical, yeah, it's on the back. And questions to be asking, have you recently gone through a growth spurt? Ask the parent caregiver, have you been buying 3 pairs of trousers every month, or what have you? Have they been eating all of the food in the house recently? Have they really been going through this growth spurt where the growth plates are a little bit more, quite a bit more vulnerable? And it's lasting pain. It's that classic stress fracture sort of thing where they might notice at the end of a session one time it's a bit sore. That builds up towards starting getting sore maybe halfway through a session. That then builds up towards them struggling at the end of a session, and you're noticing them sort of like rubbing their finger and that kind of thing. Then, they're having to stop early. Then they start missing sessions and that kind of thing. I mean, by that time, it's kind of already probably too late and they will have one. These cause lifelong issues if not addressed. You will get malalignment of the joint, particularly with the Salter-Harris 3. Yeah, early onset arthritis and that kind of thing, which if they're going to stay a climber as a climber for life, which is what we would hope for them, or I would, that's going to have real consequences later on. And so, yeah, youth shouldn't hurt from more than they can work hard, they can get some sore muscles, but they should be fully recovering between sessions. They shouldn't have any kind of lasting discomfort in their fingers. The only differentiation for that really is fingertips rather, skin. Children will often say they've got sore fingers, which sends me into a bit of a panic, and then it turns out actually they've just worn through all of their skin and they're bleeding all over the holds, which does happen. They push it hard. Moving reasonably quickly on, spondylolysis, a stress fracture in the back, reasonably common in other sports, gymnastics, trampolining, that kind of thing. When we were looking earlier at the video in bouldering, most of the new centres that are rising now are bouldering centres. This is an injury that is, again, it's a stress fracture, it's a repetition issue, particularly where extension is concerned. Climbers spend a lot of time in extension anyway, And they also, when they're bouldering, spend quite a lot of time falling from up to 4.5 meters off the ground. And so we look at the risk factors for this are lots of extension and lots of impact. Um, and so, yeah, again, children should not have lasting discomfort or pain, especially not in the lower back. Yeah, they're not middle-aged, or anything like that. So yeah, it shouldn't be coming up. So keep an eye out for that. Wanted to just do a quick, I'm aware it's already 1/2 past. Again, just a bit of sort of like what I do, some practical sort of things. These are two devices that I use. The one on the right is a Tyndek dynamometer, about 150 quid, I think they are now. The other is an active force, again, a dynamometer, more made that one for pushing. Tyndek is made really for pulling. I was very lucky when I bought my active force when it first came out years ago. They're now about 400 quid. But yeah, Tyndek is a really good bit of kit that makes dynamometry very affordable, basically. Um, Things that I look at, this is, yeah, screening. I have issues with screening, but if we come to the benchmarks that I do like to look at, external and internal rotation strength, grip strength for that central nervous system readiness, vertical jumps, neuromuscular readiness. Y balance test is a nice easy one. Um, yeah, fingers in the different grips and positions that we use, those shoulder ranges that I was looking at, if we're losing internal rotation, are we at risk of a GERD, the glenohumeral internal rotation deficit that often precedes an injury happening? So this is things that I work with coaches and individuals to be able to screen themselves and keep an eye on themselves and judge where they're at. Um, and certainly things like, a grip thing now off Amazon, 20 quid. That's what I use in practice. It seems accurate enough. It wouldn't do for research, but it's fine. Yeah, some vertical jumps. Don't need any equipment for that. Can you jump and tap where you normally do? If you're on a good day and you're feeling all zingy, shoulder ranges we've looked at, shoulder strength, and the Y balance or the ASH test, the sporting shoulder test. That's what I use the active force for quite a lot. These are things that I find pretty useful. Within this, I wanted to mention teres major. I see a lot people who've recovered, again, self-managed through a shoulder injury, and they're then presenting to me some maybe 6 months later or something like that, saying it's still, after a hard session, it's flaring up, causing me grief, that kind of thing. Tissue healing has happened. You test everything, including teres major. Everything seems okay. Coordination is really, really important in a shoulder. And so I look at people in like hangs, pulls, that type of thing, varied to their level. I have worked with an athlete once who came to see me because something was wrong with his shoulder. He realized something was wrong because he could only do 12 one-arm pull-ups, whereas he could normally do about 16. I nearly fell over. And why he's not the world's most famous, strongest climber. I don't know. Yeah, so you've got people like that, and then people who can't do a two-arm pull-up. That is also really quite common. Pull-ups are not what everybody thinks in climbing. So you have to be able to vary it, but looking at that coordination of a shoulder through the different stages of a pull. I mean, that would be a whole other CPD thing, but it's often the missing link. Yeah, are things working how they should? So if you test everything and individually things are kind of pain-free, everything seems strong, what is it? Probably coordination again, for my money anyway, my best guess. Something that's close to my heart, if we've got a minute just to just to run through this. Older climbers, not just older adults, I will blast through. This is a quick a rundown that a guy I know who lives over in Canada did of the oldest people to climb certain grades. We were looking at those grades before, up to like 7A plus. 9C is the current hardest. And people in their 60s and 70s, climbing really hard. Really, really good to see. These are people that most people who climb and have climbed for a while would know the names anyway. They are the outliers. They are the elite. They are the real athletic achievers. So it's potentially no great surprise that they're still going well as they get old. But if we're able to stay healthy, which is a separate thing, isn't it? People should expect to be able to continue to climb for a long time. Main issues is tendons. And if I had to summarize quickly here, um, long duration isometric work to help improve aged tendons, which tend to become quite brittle and stiff due to the changes that happen as we age. Yeah, not got time to go into all of that now. The other thing that often gets asked, fingers, arthritis, damage. Yeah, adaptation or damage is the question here. These are the fingers of a friend of mine who climbs in the eights, so a good high level climber in his 40s, been climbing for 20 odd years. We can see calcification of tendons. We can see lots of bony overgrowth. We can see all sorts going on within here. And he has no finger symptoms whatsoever. He happened to be having an x-ray because he thought he might have broken his little finger in an entirely unrelated incident. He is a first contact physio and reported to the hospital where he works and asked, would you mind while I'm here, can I just have a few more x-rays of my fingers to see what's going on? Yeah, and lots that a radiographer would look at here and go, oh, blimey, that's pathological. But he has, yeah, no issues, no pain whatsoever. Similar to runners, climbers will have potentially more cartilage in their finger and fingers than people who don't climb. But again, there's always that, then elite runners, far more likely to have knee replacement because they do too much almost. So there is a balance to be had. But yeah, in general, there's been studies done. We're at that point now where we can, sort of like longitudinal studies done over a decade or so. And yes, they will get arthritic changes. That's just part of aging. Climbing itself may, in some ways, accelerate what we see as arthritic changes, but also builds the connective tissue and muscular resilience to be able to deal with those changes. So again, if somebody got this X-ray, then you may get a report that could cause that climber some disconcern, essentially. But we need to actually look at what their function is. Right, I shall stop waffling there. I'll stop sharing. He says.
Oh, amazing. Thanks, Andrew.